So, good evening, everyone, and welcome to today's wonderful evening. And we used to have a very long tradition of every Sunday a grand test, and following the grand test, there is a discussion. So, akkada off chain, akkada voice off chain. So let's start with, I hope you answered 200 questions. Hopefully, next week onwards, try to answer all the 200 questions. The only long bone in the body with two primary centers of ossification. So basically, clavicle has a lot of specialities. I think you know very well that clavicle is the one which is the only long bone which is horizontally placed. Then there is two primary centers of ossification, etc., etc. Now, the nutrient artery, every bone has a nutrient artery. So the nutrient artery of the humerus, it is the branch of which artery? So it is the branch of the profunda brachii is what we need to emphatically remember. Lesser sciatic notch. What are the structures that pass? So this is one batti marne wala question, which you have to be very sure. The tendon of obturator internus, internal pudendal vessels, pudendal nerve, and the nerve to obturator internus. Obviously, tendon of obturator internus, nerve of obturator internus, internal pudendal vessels, and the pudendal nerve. So that is the reason easy to remember is PIN. P is pudendal vessels. Sorry, P is pudendal vessels. N is nerve, which is pudendal nerve, and I is basically internal pudendal vessels. N is nerve to obturator internus. Sorry, nerve to obturator internus. P is pudendal nerve and pudendal vessels, and tendon of obturator internus. Now, how is the neural tube formation is initiated? So you should remember that it is the upper cervical area where the neural tube formation is initiated is what you need to remember. Then another favorite question of the examiner is, what are the derivatives of neural crest cells? So every entrance you go, this is such a standard stock mnemonic based thing that you need to write in your book and go to exam. Without a neural tube crest cell derivatives, there is no question paper. Is there any buzz sound coming or is it clear? Clear. Okay. So these are all the structures which are derived from the neural crest cells. Sympathetic ganglia, parasympathetic ganglia, dorsal root ganglia. So you can remember motile pars, melanocytes, odontoblasts, tracheal cartilage, enterochromaffin cells, and laryngeal cartilage. Similarly, parafollicular cells, pseudo-unipolar cells, all ganglia and adrenal medulla, Schwann cells, spinal membrane, you have to emphatically remember for the tomorrow's exam. Now, what happens when you are exercising your skeletal muscles? That lead to vasodilatation. Vasodilatation. So, vasodilatation will decrease the total peripheral resistance. So, there is a decrease of the arteriolar resistance is what you need to remember. What is the most important method for transporting the carbon dioxide in the blood, which is produced in the muscles, the activity of the muscles? Remember, the most predominant form undoubtedly is bicarbonate, is what you have to remember. Bicarbonate. Now, gastrinoma, gastrinoma. How do you know with the secretin stimulation test. So normally secretin inhibits the antral release of the gastrin. Normally secretin is supposed to inhibit the antral release of the gastrin. But if there is a gastrinoma, it does not listen to the word of secretin. So even if you give secretin, the gastrin continue to get produced. That loss of inhibition of the gastrin production with secretin is the nature of the gastrinoma. Always excess hyperfunction. How do you test in endocrinology or anywhere? You will suppress. Hypofunction, you will stimulate. Even if you stimulate, if it is not getting produced, means the organ is hypo. Even if you suppress, it is not getting suppressed, means it is hyper. Simple point to basically remember. A 24-year-old man, he lifts 200 kgs on his head and holds it for 7 seconds. So whenever you are doing weightlifting, what are those sensory receptors which lead to sudden muscle relaxation is the question of the examiner. It is the Golgi tendon organ that you need to basically remember. So the Golgi tendon organs, typically whenever there is a sudden muscle relaxation, then the Golgi tendon organs are the ones which basically stimulate. And that is basically called inverse stretch reflex, otherwise called autogenic inhibition. Now, muscle spindles, Golgi tendon organs, doctor. Sure, short MCQ in the tomorrow's exam. Muscle, spindles, and Golgi tendon organs. Golgi tendon organs. Very good. So, Pacinian corpuscles. You have to be very sure about Pacinian corpuscles. For that matter, one of the very high-yield topic, sensory receptors, is a very high-yield topic, doctor. Today only, after going home, you have to do the revision of Meissner's corpuscles, Pacinian corpuscles, etc. Please give to Dr. Sir the printout of the ENT. ENT is there, no? Give a printout to him so that there are 2,500 points in ENT, just like 8,000 sure shot points in general medicine. So totally 65,000 points, and we are in the process of preparing notes. So right now ENT may 450 points are ready. He will give you the printout. So every day I'm getting time to write about 400 to 500 points notes by sitting for 6 to 8 hours. I'm sure within about another 6 months, I will be launching the entire 65,000 points notes, right? So, Pacinian corpuscles. Which intestinal hormone it is stimulated in response to the intraluminal glucose and fatty acids in the gut is a very important question. It is the gastric inhibitory peptide which get stimulated. And where is it produced, doctor? Duodenal and jejunal mucosa. And there are K cells which release the gastric inhibitory peptide is what you need to remember whenever you eat a lot of glucose, whenever you eat a lot of fatty acids. Now, Tay-Sachs disease, hexosaminidase deficiency. Typically, in Tay-Sachs disease, the degradation of the glycolipids in the brain that become affected because hexosaminidase A, it hydrolyzes the N-acetyl glucosamine and galactose in the galactoside, in the ganglioside is what you need to remember. Vitamin B12 deficiency lead to methyl malonic aciduria. See, basically acetyl-CoA become malonyl-CoA. Malonyl-CoA. So this malonyl-CoA, for it to further get metabolized during the beta oxidation, see, typically there are two types of fatty acids. One is even carbon, other is called odd chain. So if you take 16 carbon, then every time beta oxidation is happening, acetyl-CoA 2 is gone. So 2 into 8 times 16, it breaks down into 8 acetyl-CoA molecules. But if it is a 3 carbon one, then the last one that is produced is a 3 carbon one, malonyl-CoA. So whenever odd chain fatty acid oxidation occurs, vitamin B12 is required. So whenever that is not there, then that lead to methyl malonic aciduria is what you have to basically remember. So this methyl malonyl-CoA becomes succinyl-CoA. Succinyl-CoA enters into citric acid cycle. So that's how the metabolism goes on. For that you require methyl malonyl-CoA mutase, which is missing if the vitamin B12 is missing. And that affects the fatty acids, odd chain fatty acid oxidation to get affected is what you have to basically remember. Leukene's muscular dystrophy. What is the type of inheritance? There are 5 or 6 conditions which are X-linked, recessive, color blindness, etc. So it is X-linked recessive inheritance is DMD. There's only one condition, X-linked dominant. Do you know what is that? Vitamin D resistant rickets. Resistant rickets. It's also called phosphate diabetes. Phosphate diabetes is the other name given for that. So vitamin D resistant rickets is X-linked dominant is what you have to emphatically remember for the tomorrow's exam. I'm very happy to see at least 4 online classmates in the YouTube channel. Now it has become 5. Very good, very good. So every Sunday, doctor, whatever it is, they will have a full-scale grand test and a question paper revision. So more than coaching, what you require is inspiration, right? Inspiration to prepare is more important. That is the role of a coaching guru. Uronic acid. Where is it absent? Keratin sulfate is the only glycosaminoglycan which does not contain the uronic acid. So hyaluronic acid contains glucuronic acid. Dermaton sulfate contains the uronic acid, and chondroitin sulfate contain glucuronic acid once more. What is an example of a quaternary structure out of all this? It is the hemoglobin, which is having a quaternary structure. So hemoglobin is a tetramer of 4 polypeptide chains. So it is the best example of a quaternary structure of a protein. Primary structure means amino acid sequence. I think you know that. A 6-year-old, the skin lesion is being shown. So what do you see? Scalded skin syndrome. Very good. It is staphylococci. And what do you see here? We see rhizopus. And fatal hemorrhagic fever is because of Ebola virus, which has got an incubation period of around 2 to 21 days is what you need to remember. And what do you see here? Tinea capitis, a dermatophyte infection. So you treat it with oral greaseprevir. Now, what is this organism that is being shown to you? So it is a bacteriophage, which is fundamentally a virus, and it causes transduction, and it leads to the lysis of the bacteria. They're all true statements. So what is this distribution of the epidemic, basically? It is the Japanese encephalitis. It is most prevalent in Southeast Asia, is what you need to remember. Now you have given patient 200 milligram dose of the drug intravenously. Whenever you give the drug intravenously, what happens, doctor? Bioavailability is 100%. 100 mg was eliminated during the first 2 hours. That means half-life is 2 hours. So if it is following first order kinetics, 6 hours passed, what will happen? 3 half-lives are over. 100 become 50, 50 become 25, 25. So 25 milligrams. Okay. So then, whenever a drug is highly bound to albumin, albumin से bind होना शादी करने का बराबर है. So if you marry, you can't go around, hang with your friends. You have to give your time, energy, flesh, blood, tears, sweat, everything to your partner. So the volume of distribution become low. Highly, what is volume of distribution? Basically, there is plasma. And there are extra vascular tissue. Right? So you have a drug. If it is highly protein bound, it cannot go into the extravascular tissue. So that is the reason it will remain in the plasma. That's the reason the volume of distribution become low, is what you need to remember.
If a drug is present more in the plasma, volume of distribution is low.
If
a drug is present in the plasma, volume of distribution is low.
Low, obviously, because volume of distribution means amount of the drug available in the plasma and also outside the plasma. The entire thing is VD. But if it is limited only to plasma, it is not distributed outside, low volume of distribution. Similarly, if you take a drug like thiopentone, it has a high lipid solubility. So it becomes quickly distributed into the extravascular tissue. And it has got a high volume of distribution. And because of this high volume of distribution, the drug is, once you inject, it becomes rapidly distributed. And that's the reason the elimination is faster. That's the point about thiopentone. Okay, good. Midazolam is an effective anesthetic. Why? Because it facilitates GABA-mediated increase of the chloride ion conductance. Chloride ion conductance lead to hyperpolarization. Just like sodium ion conductance lead to depolarization. And potassium conductance lead to repolarization. So these are the points that you need to basically remember. Long QT syndrome. What is the appropriate drug? If there is a long QT syndrome, the other day we discussed long QT syndrome. Long QT syndrome. Today we are missing Anusha in the class. Or today is Easter. So I think Anusha had been to. Last week we had a very good pen and paper discussion of the cardiology, right? So long QT syndrome lead to polymorphic ventricular tachycardia, torsidis depointis. So you should know what are all the drugs that predispose. Gabapentin does not. So that's the reason you can safely give the gabapentin to this individual. Oseltamivir, zanamivir, they lead to inhibition of what? They lead to inhibition of the neuraminidase is what you need to remember. So once more, all antiviral drugs, okay, and their mechanism of action. Tips में रहना, examiner को इतना भी chance नहीं देना. So I am preparing 65,000 high yield facts covering 19 subjects. Barabar notes I will give you. Totally 2,500 pages ka notes hai Babuji. And mastering this 2,500 pages notes is like Tirupati Prasadam, right? So I am the Swamiji for NEET PG topping, not a controversial Swamiji, regular Swamiji. So doctor, pseudomembranous colitis, vancomycin, is considered to be the treatment of choice. Now, mast cell के ऊपर anaphylactic reactions में it is the immunoglobulin E, which is very, very important. Post-infectious glomerulonephritis. I'm so happy to see 5 online classmates. Very good, doctor. Very good. Is the broadcast okay? Online? Good. Post-infectious glomerulonephritis. Typically, most cases in an epidemic are all subclinical, is what you need to remember. And post-infectious glomerulonephritis is more common with cutaneous streptococcus infection. Unlike rheumatic fever, which is due to pharyngitic strains, glomerulonephritis, which is post-streptococcal, is because of the skin infections of streptococcus. That's what you need to remember. Then delayed type of hypersensitivity reaction. So what do you see in this? So basically delayed hypersensitivity example is tuberculin test. So caseating granulomas in the hilar lymph nodes, type 4 hypersensitivity, right, is what you need to remember. Now, one thing, doctor, immediately after going home, what is Dr. Teja going to do the revision? Apoptosis. Okay, what is your answer for this question? Any guess? If you answered this question wrong, you are 20,000 ranks behind. Come on. Very good. Caspase 8. You are 20,000 ranks ahead. So don't worry. Everything, anything about apoptosis, doctor, you should nail it and scale it. Okay? So caspase 8 is what you need to remember. So there are some pro-apoptotic, anti-apoptotic, like the back, they promote. Then they are similarly bad, BK, Noxa, Puma, HRK, all this stuff, doctor. You have to be sure. Then what are anti-apoptotic? BCL2, MCL1, everything you should remember. Now, pseudo-palisading necrosis, endoneural proliferation, hypercellularity, atypical nuclei. Where do you see? Glioblastoma multiforme. Glioblastoma is a worst variant of glioma. Glioma is nothing but astrocytoma. Both are same. Astrocytoma, glioma, both are same. In this you have grade 1, grade 2, grade 3, grade 4. Grade 4 is the dirtiest thing. And that is called glioblastoma multiforme, is what you need to remember. Now, osteoid scenes are prominent. Large osteoclast, 12 hyperchromatic nuclei, viral type inclusion particles. What does it suggest? Paget's disease. So Paget's disease. Histology of Paget's disease. Today only you should go back and check in the Wikipedia, wherever possible, how the histology of the Paget's look like. Now, till how long you can pull out a buried cadaver in India? Anytime, whenever you are hungry, you can pull it out. No time limit. Cyanide is bitter almonds. Then aconite poisoning, we use atropine. Always atropine is vagolytic. Parasympathetic system slows the heart. Right? Parasympatholytic is atropine. Atropine speeds the heart. That's the reason whenever in organophosphor poisoning, whenever you give atropine, what will you do? You will see to that the heart rate has crossed more than 100 to consider adequacy of your atropine treatment. Okay? Now, according to the Indian law, what are considered to be rape? Rape means penetration of the penis into the female vagina. That's the reason a man can rape a woman. Woman cannot be accused of raping a man. Because women cannot be able to do a penile penetration. Then, any sexual intercourse done through the anal route, anus is not vagina. So that's the reason it is not considered to be rape. It is called as unnatural sexual intercourse, is what you need to remember. Ecbolic increases the uterine contractions. Complete cessation of occurrence of a local transmission of the cases is called as elimination. We are all praying for that to happen for the COVID, but we don't know. Now, how do you get cognitive domain of learning? Cognition means acquisition of skills, right? So, basically, there are various ways: folk play, role play, etc. Lecture is the way of cognitive domain of learning. So, multi-purpose health workers are because of which committee? Kartar Singh committee. How much water is required daily? 180 liters. Problem village means what? Distance from the water source more than 1.6 kilometers is what you need to remember. If the birth weight of 10 babies is uniformly 2.8 kg, so how will you calculate standard deviation? So basically, if you look at the formula of standard deviation, from the mean value, how much is a particular value away from? Here, the mean value itself is 2.8. So 2.8 minus 2.8 is 0. Because everybody is 2.8, there is no standard deviation, it is 0. So you should know the formula of standard deviation. Mean glucose is 86. Right? Mean glucose is 86. In a sample of 100 showing normal curve distribution, how many people will have a glucose above 86? So always mean represents 50%. Okay. Now histogram is used to plot the frequency polygon. So what we will be doing is, you will take the midpoints and connect them. And that's how you get the frequency polygon. Right? Now, a sewage is considered to be severe, moderate, simple, etc. What is the basis? It is the suspended solids. Biological oxygen demand is more than 500. Is that nasty value? You need to remember for the tomorrow's exam. And there is no other option, doctor. We have to remember, right? Standard error If you want to know the group variability, if you want, one is tall, one is short, one is fat, one is thin. So group variability, standard error is the one which is utilized. Once more, phase 1, phase 2, phase 3, phase 4 trials. You need to know everything. Basically, phase 1 is all those animal studies done in order to know the toxicity profile. Now, regarding cold chain system, PHC can hold more than 1 month of supply. Cold boxes cannot be used for storing. You need to find the vaccines are never stored in sub-center for 1 month. But PHC you can store because you have that refrigeration facility is what you need to remember. Central crushing chest pain for the first time. And PDCA, what is it showing? Left circumflex circulation is affected, right? It's blocked. Whereas left anterior descending and all that is fine. So you should know that the left circumflex results in lateral infarct. V5, V6 are lateral leads. So V1, you know very well, V1, V2 is anterior and supplied by LCA and diagonal branch of LAD, left anterior descending. Left anterior descending is also called widow's artery. Widow's artery, because a lot of people became widow because of sudden occlusion of the left anterior descending artery. V3, V4 is called septal. It is the septal branch of the LAD and LCA. V5, V6 is called lateral. It is the left circumflex artery which is responsible. V1 to V6 is called anterolateral, and it is the left main stem disease which is responsible, is what you need to remember. A 78-year-old woman is admitted with heart failure and blood pressure is 150/90, pulse rate is 60 per minute. Aortic valve is being shown to you. So this is most important thing, doctor. How this is more circular instead of being triangular. So circular means it is more severe form of aortic stenosis, right? So severe aortic stenosis lead to left ventricular failure, and that lead to pulmonary edema, because of which you get bilateral basal crepitations. That's what you need to basically remember. A patient is admitted with pneumonia. Blood pressure is 130/80. And echo is being shown to you. So what do you see in the echo? So you should remember that always, is it a right side or a left side valvular lesion? That is important to identify. So typically, right-sided lesions, the blood supply to the lung can increase, and that lead to development of pneumonias, recurrent pneumonias. So the murmur typically in inspiration will be higher if it is a right-sided valvular lesion. And mitral, what you are seeing here is mitral valve lesion. So that is best identified in if you do make the patient lie down in the left lateral position. Okay, so that's a point you need to remember. 79-year-old hypertensive, fasting glucose is normal, cholesterol is 5.2. Her ECG is being shown to you. So what do you see here? There are QRS complexes, but there is no P wave. Atrial fibrillation. So what is the treatment? Warfarin. So you should know CHAD2 score when you want to start anticoagulation. What are the indications for anticoagulation is what you have to be very, very sure about. Congestive heart failure, hypertension, age more than 75, diabetes, previous stroke or TIA. that has 2 points. That's the reason it's called S2. 2 points. Remaining all have 1 point. That is the CHAD S2 score is what you have to basically remember. Good. And the online students can punch whether the voice is loud and clear for all of you, doctor, right? So every day evening, 6 p.m. to 8 p.m., doctor, starting from day after tomorrow, every day evening, 6 p.m. to 8 p.m. Monday to Wednesday, we will have Dr. Chandrasekhar, who will be delivering a live class in ENT. And Thursday, Friday, Saturday, I will come to the center and I will be delivering preventive medicine. There are 4,000 points in preventive medicine. A lot of times students have a struggle in preventive medicine. I thought of starting general medicine, but all the final year students are coming into, ENT ophthalmic guys are coming into general medicine in the month of June ending. So that's the reason June ending onwards we'll be starting medicine, surgery, gynocs. Before that we finish ENT and SPM, which will also be helpful for the ENT SPM exam going students, not only entrance prepare, right? So there are about 4,000 points in SPM, 2,500 points in ENT. I'll give you the notes. It will be 100 pages notes in ENT and another 150 pages notes in SPM. You don't need any other notes, only that notes, those points. Acha, kabu mein le lo, definitely aayega seat, right? But every point you have to analytically analyze and absorb. That is most important thing, doctor. Can the online students can punch? Is the voice loud and clear? Is the voice loud and clear? Monday? Monday, Tuesday, Wednesday. 3 days, evening 6 to 8 p.m. ENT, Chandrasekhar sir comes here only. You can come. Very good teacher. Then Thursday, Friday, Saturday, I come, SPM. Sunday, we have a grand test and discussion. Right? So that remaining time, you plan last moment what best you can do. Hardly another 5 weeks to go. Right? Very good. Is the voice okay? Clear? Good. Now, a 55-year-old man just arrived in accident and emergency with a central crushing chest pain and found this is the ECG, right? So what you can see here, V2, V3, you have a ST segment elevation. So always ST segment elevation is the most important indicator. So once more you should remember, whenever patient is having acute coronary syndrome, then if a transient ST elevation is there, it is pringemental angina. Then there is a possibility of unstable angina or MI. In the MI, you have two varieties, ST elevation MI and non-ST elevation MI. So you should differentiate the two. Especially the challenge will be, now what is the difference? In ST elevation MI, there is an ST elevation and CPK MB elevation, troponin elevation and all that. So cardiac enzymes are elevated, ST is elevated in ST elevation MI. Non-ST elevation MI, ST is not elevated, but cardiac enzymes are elevated, which is equivalent to ST. Then unstable angina is no ST elevation, and no cardiac enzyme elevation. So there is no infarction, there is only ischemia. So that is unstable angina. Okay. Now 66-year-old woman comes to accident emergency, 2 days history of shortness of breath. She also has a pain in the right leg. Always shortness of breath, pain in the right leg means DVT, pulmonary embolism. Khatam. You don't need to see anything else, but still what do you want to see here? S1, Q3, T3 in the lead one. In the lead one, you can see S1. S means what? After the positive R wave, the negative wave is called S wave. Can you appreciate that? S1. Huh? Then S1. Q3, negative wave is Q. And there is also T wave inversion. Are you able to appreciate? So S1, Q3, T3 is what you see in pulmonary embolism is what you need to remember. A 59-year-old, no significant finding except a systolic murmur, mid-systolic click. You remember our last week discussion? So, see doctor, one simple understanding of the echo. From left atrium, blood goes into left ventricle. From left ventricle, the blood goes into aorta. That's the reason this valve is what? Aortic valve. And this is interventricular septum between left ventricle and right ventricle. And here you have the anterior leaflet of mitral valve. This is the posterior leaflet of mitral valve. So this is parasternal view, like Padmanabha Swami, the what you call heart is seen, like Trivandrum's Padmanabha Swami is lying down. So the blood goes from left atrium to left ventricle, and from the left ventricle goes into aorta. Right? So what happens in this thing, HOCM, the interventricular septum is thick, and this mitral valve leaflet together will come and touch each other, and that will prevent the blood from going from left ventricle into the aorta. Appreciate it? That is very important. So mitral valve prolapse is what you see here. You can see the prolapse of the mitral valve. See, it is prolapsing back into the left atrium from the left ventricle. Agree? So this is also called Barlow syndrome is what you need to remember. A 60-year-old man presents with a 3-day history of severe chest pain. The pain is sharp. The pain is tearing. The pain is sharp. The pain is tearing. And it is radiating in the interscapular area in the back. There is a widening of the mediastinum. So the diagnosis is aortic dissection. Uncontrolled hypertension is the one which is responsible for the aortic dissection is what you need to remember. 49-year-old man, 20-minute history of severe crushing chest pain. You have given glyceryl trinitrate spray and his ECG is being shown to you, right? So what is the most appropriate treatment, especially when he is allergic to aspirin? So always there are two things to control the pain in a suspected MI. One is to give glyceryl trinitrate. If not alleviated, then you will give morphine. But here already it is alleviated by giving GTN. This is the no need of morphine. But he is allergic to aspirin. That's the reason you need to give clopidogrel in order to treat, is what you need to basically remember. Now, there's a lightheadedness, palpitations, and the patient is breathing, oxygen saturation is at 97%, and you are unable to find the radial or carotid. So what do you see here? Polymorphic ventricular tachycardia. So ventricular fibrillation. In fact, more than polymorphic VT, VF here.
So in this polymorph, that's why
Ventricular tachycardia can be simple monomorphic, like this, like wide QRS complexes. That's the only thing. The second type is polymorphic VT. Such a polymorphic VT anytime can become ventricular fibrillation. That's what happened here. Right? Now, ventricular tachycardia can be sustained or non-sustained. Sustained ventricular tachycardia, typically, if the patient is stable, then you can cardiovert him with imidinol. But if he is unstable, then electric cardioversion. Unstable means hemodynamically unstable. Electric cardioversion is being done. Then, when do you call non-sustained VT and sustained VT? The other day we have discussed the definitions of sustained and non-sustained. Did we? I think we did not reach that point. Okay. Anyway, we'll have a proper cardiology review. There are totally about 1200 points in cardiology. 67-year-old, 3-day history of shortness of breath. And ECG reveals the following changes. So what are you able to see here? So once more, there is a irregular rhythm. You are able to see, no? These two are wide, these two are narrow, these two are narrow. This is once more wide, irregular rhythm. No P wave before QRS. That means atrial fibrillation. So typically they will not have A wave in the JVP, is what you need to remember. A 78-year-old. Wow, that's good to see. 6 online students. Very good, doctor. So, at a point of time, we used to have 400, 500 students online also. But the question is, students need a continuous availability. So, yeah. 3-day history of shortness of breath, productive cough, white frothy sputum, bilateral basal crepes. You're suspecting CHF. X-ray was done. Now, in CHF, what is the feature which is not seen? So you should remember reverse moustache sign. So there is a prominence of the pulmonary vessels becoming prominent in upper lobe, upward direction, not downward. That is classical feature. Then bat wing appearance of the pulmonary edema. Increased size of the heart. So they are all the features. So upper lobe diversion, not lower lobe diversion, is what you typically see. 56-year-old man with exertional chest tightness, relieved by rest. ECG is being shown to you. Always exertional chest tightness, relieved by rest, is an important clue. And now the question comes. First degree heart block means what is our definition? Other day we discussed. Come on. If you don't answer, I will be sad. What is the definition? PR interval more than 200. చెప్పుకున్నాం కదా. ఒక పెద్ద డబ్బాలో 5 స్మాల్ డబ్బాలు ఉండును. 5 small dabbalu is equal to 5 small boxes. Each small box is equal to 40 milliseconds. 5 small boxes is equal to 200 milliseconds. Otherwise, 0.2 seconds is the normal PR interval if it prolongs more than 200 milliseconds. Normally, it is 0.12. 3 small boxes. So the start of the P wave to the start of the QRS, you call it as PR interval. You see 57-year-old woman, worsening shortness of breath, and she has murmurs. She underwent 2D echo, as what you can see here. Now, what is the condition associated with this typical thing? So here, doctor, you can see this is called hockey stick sign, like a hockey stick. That happens whenever there is a mitral stenosis. Mitral stenosis lead to mid-diastolic murmur, loud S1, opening snap, pre-systolic accentuation of the mid-diastolic murmur. You have to master. Pansystolic murmur radiating to axilla is a feature of MR, not MS. 62-year-old with palpitation CCG is showing the following finding. Once more, atrial fibrillation. So now the examiner is asking, what do you prefer as a first-line therapy? So basically, if the onset of arrhythmia is recent, there is no chance of intramural thrombi. There you can do DC cardioversion. But if it is a little chronic AF, then you need to anticoagulate first and then do the cardioversion. That's the point you need to remember. 76-year-old male. 76-year-old male brought to accident and emergency after collapsing at home. His blood pressure is 115 by 88. थोड़ा AC बंद करना. Yeah. Then what do you see here? What is the axis? Lead 1 is looking up. Lead 3 is looking down. So left. Very good. Left axis deviation. And you are able to see V2, V3 showing ST segment elevation. Right? So, and also what else do you see? Not ST segment elevation, but prominent Q wave. Then T wave inversion is there and significant. QRS became very tall. The other day we discussed Leon-Sokolov's criteria. Did we? No? Of left ventricular hypertrophy. The height of the R and the depth of the S, you will add the two, and what value will be defined as a left ventricular hypertrophy. I will do a revision for you, right? So, Leon-Sokolov's criteria. So, left ventricular hypertrophy is there. Aortic stenosis is the diagnosis. And aortic stenosis has got crescendo systolic murmur best heard in the right sternal edge is what you need to remember. 56-year-old, 2-hour history of central chest pain radiating to left arm. ECG is showing ST segment elevation V2, V3, right? V2, V3. And that puts the diagnosis to the right coronary artery. So normally, right coronary artery supplies inferior wall and posterior wall. So always remember, if you look at the lead V1 to V6, right? Lead V1 to V6. Electrical wave is passing from V1 towards V6. So that is the reason by the time you go to V6, the positive R wave will be prominent. And you don't find prominent R wave in V1. V1 is supposed to show small r and a significant yes. But if the V1 is showing, V2 is showing, prominent R wave means, when do you see that? So V1, V2 are what? Anterior chest leads. If there is an infarction in the posterior wall, then you expect a Q in partial lead, but there are no partial leads. Instead, you find reciprocal of the Q is prominent R in the V1, V2. Normally, V1, V2 does not show a positive R wave. But if there's a positive R wave in the V1, V2, V3, that is a reciprocal change of the Q wave whenever there's an infarction in the posterior wall that reflects in the anterior leads as a reciprocal to Q wave, that is prominent R wave. That's the point you need to appreciate. Now, doctor, the next question. 57-year-old, what is here? Papilledema. Presence of the papilledema is indicative of malignant hypertension. So there you need to emergently treat with sodium nitroprusside. So hypertensive emergencies and urgencies, you need to know the difference between the two. 16-year-old referred with for hypertension. There is a mid-systolic murmur maximal in the aortic area and radiating to the back. There is a left ventricular hypertrophy, right? So what do you see here? Notching along the inferior margin of the rib, which is typically seen in a hypertensive individual, means coarctation of aorta. Because the collaterals that develop, that lead to the notching, intercostal vessels become collateralized whenever there is any constriction in the aorta for the flow, right? That lead to inferior rib notching. Where do you see superior rib notching? Neurofibromatosis. All stupid points. But for entrance exam, okay, we need to remember, like a fun. So 16-year-old diagnosed with the condition shown below. So what is the important complication? What you see here is a VSD. So VSD has a complication of developing infective endocarditis. Between ASD, VSD, which is a high pressure shunt VSD. So VSD is vulnerable to infective endocarditis, very high. But ASD, low risk lesion. That I think you know that. Now, 52-year-old woman, amlodipine, lisinopril, persistent left loin pain. Both the kidneys appear to be enlarged. Hematuria is there. Ultrasound is showing these cystic structures, which are typically polycystic ovarian syndrome. Sorry, polycystic kidney disease. So polycystic kidney disease identified by ultrasound is the best investigation. 61-year-old, 2-hour history of moderately severe retrosternal chest pain. Troponin are not elevated, and the ECG is being shown to you. What is the next best step? So What the patient is having is an acute coronary syndrome, right? So in acute coronary syndrome, first you need to administer the IV low molecular weight heparin is what you need to remember. And if the patient is not there on the beta blocker, better introduce beta blocker. So presently there is no ST elevation changes, right? But the pain is 2-hour history. That makes it unstable angina rather than a stable angina, right? Which is less than 30 minutes. Now, 41-year-old, dyspnea, palpitations for the second time. The ECG is showing this finding. What is the next step in management? Once more, this is an ECG of what? S1, Q3, and T3. So you need to do thrombophilic evaluation. So what are the conditions that predispose to the clot, antiphospholipid antibody syndrome, nephrotic syndrome, right? Thrombophilic conditions, factor V Leiden mutation, hyperhomocystinemia, etc., etc. 32-year-old, mid-diastolic murmur with opening snap, finish. The moment you say mid-diastolic murmur with opening snap, it is mitral stenosis. So best investigation is what? Echo. What you are seeing is actually normal ECG. So what do you expect in ECG whenever there is a mitral stenosis? If there is a severe mitral stenosis, that leads to severe pulmonary hypertension. Whenever severe pulmonary hypertension is there, you find prominent P waves, which is called P pulmonale, is what you need to remember. Similarly, the severe mitral stenosis can lead to left atrial enlargement, and that lead to M-shaped, like McDonald, the P wave. That's called P mitral. So these are all the things that you see in mitral pathology. A 46-year-old man develops sudden severe central chest pain after lifting heavy cases while moving the house. The ECG is normal. He is distressed, sweaty, but not nauseated. And there is a pain going to in the interscapular area. So what do you see here? Aortic dissection with the flap, the dissecting vessel. All this is blood, and that made the lumen become condensed. And here you can even see that dissected flap. So it is aortic dissection. 49-year-old, increasing shortness of breath, 158/61, decrescendo diastolic murmur. So there is a regurgitant lesion. Early diastolic murmur is a feature of aortic regurgitation. Lub, right? Like a post-coital sound. So 21-year-old, sudden onset of rapid palpitations, SVT is being found. How do you identify this as SVT? QRS is narrow. Tachycardia because more than 100 heart rate. Last week we discussed IV adenosine. IV adenosine is the treatment of choice. 44-year-old women, and ECG shows the following changes. Troponin did not rise. So what do you like to do? So there is a multiple ST segment elevation, fringemental variant angina. 19-year-old man, unusual shortness of breath, left axis deviation, left ventricular hypertrophy, and the echo is shown. So what do you see here? The blood flows from left atrium to left ventricle, from left ventricle into aorta, and here you have the mitral valve, antral leaflet, which is coming close to the hypertrophied interventricular septum. They both are touching and causing obstruction to the flow of the blood from the atrium into the ventricle, from the ventricle into aorta is what you need to remember. So, the other day, what did we discuss? Beta blockers decrease heart rate, increase diastolic time, filling time, increase the filling of the ventricle become bigger and the touching become lesser. That's the reason we give beta blockers. Don't give nitrates, don't give digoxin, but give beta blockers. That's the treatment of HOCM is what you need to remember. A 45-year-old woman, 45-year-old woman, increasing shortness of the breath on exertion, orthopnea. There is a low voltage, especially in the low limb leads. So you are able to see the chest X-ray. So what is it consistent with? So it is, you are able to see the effusion, cardiac tamponade, elevated JVP, Kusumal sign. That's what you need to basically remember. 21-year-old treated for congestive heart failure, complaints of nausea, anorexia. There is a visual abnormality. What is this? Everything looking yellow. Xanthopsia, it's called. Xanthopsia, which is a feature of digitalis toxicity. And what do you get on ECG if there's a digitalis toxicity? Dali's Mustad sign. Check mark sign. That's what you typically come across. Then 29-year-old, fatigue and palpitations, lost weight, and there is an atrial fibrillation. So, one of the very common causes for the atrial fibrillation is presence of hyperthyroidism that you should always rule out. 58-year-old man recovered from interval MI, ECG showing the old Q waves. So pathological Q wave, you are able to see. All right. So secondary prevention. What do you use when the patient is getting discharged from the hospital after a MI? So don't forget aspirin, lisinopril, simvastatin. They're all the part of the secondary prevention. Omega-3 fatty acids come under primary prevention. घर जलने के पहला, घर जलने के बाद जो होता है वो होता है secondary prevention. बराबर? Now, 25-year-old mitral valve collapse, low-grade fever, night sweats, microscopic hematuria, and what do you see? Roth spots, Osler's nodes, which are painful, Janeway lesions, which are painless. Right? So, these are all the features of infective endocarditis. And what is the most important investigation to prove IE? Always blood culture. Blood culture is the gold standard for diagnosis. A symptomatic 31-year-old woman, she underwent 2D echo, and that reveals this finding. So, what are you able to see? So what we are able to appreciate is a prolapse. Mitral valve prolapse is what you need to remember. Newborn infant will have a large head, large liver, shorter extremities, right? Body proportions. Then normal 4-week-old infant has a monoreflex. Recurrent respiratory infections is a feature of VSD, ASD, any GE reflux. But what do you have in tetralogy of Fallot? Tetralogy of Fallot, there is a VSD, right ventricular hypertrophy, and into the pulmonary artery, pulmonic valve is stenotic. And there is an overriding aorta opened its mouth into both right ventricle and also left ventricle. So pulmonic stenosis means there is a decreased blood flow to lungs. Anything that decreases blood flow or increases blood flow will cause infections. Pneumonia is more common if the pulmonary blood flow is increased, like in ASD or VSD, not in tetralogy of Fallot, where it is in fact decreased, is what you have to remember. A boy aged 2 years, delayed milestones, muscular hypotonia, depressed tendon reflexes, right? So all these are spinal muscular atrophy. And any normal CPK excludes the diagnosis of Duchenne's muscular dystrophy. Newborn babies. Newborn babies. What is correct about newborn baby? Any jaundice occurring the first day is pathological. Right? First day is pathological jaundice. So usually hemolytic or intrauterine infection, they lead to jaundice appearing on the first day of life. Then post-maturity means beyond 42 weeks of gestation. Now, a full-term infant, he is having a high hematocrit. A high hematocrit is a possible cause of respiratory distress because the high viscosity, right, is what you need to appreciate. Herpes simplex infection, it usually is acquired during delivery. It is a type 2 virus. Always type 1 is oral, type 2 is below. Then it can cause the jaundice before the 3rd day of life. That is also true. Is what you need to remember. Acyclovir treatment is known to be effective, not cytosine arabinoside. Pertussis is contraindicated whenever the temperature is very high, typically contraindicated. Then acute bronchiolitis. Acute bronchiolitis, always remember, first episode of asthma and RSV associated bronchiolitis, they both are close differential diagnosis. You should differentiate this or this. In fact, this also is lead to hyperinflated lung. Even bronchiolitis also lead to hyperinflated lung because the air is trapped inside the airway, right? So both of them lead to hyperinflated lungs. Stuck-on crust appearance is a feature of impetigo. Alopecia, scutulae, they're all the features of the favus infection. Tintac appearance is seen in the DLE. So carpet track sign, Tintac sign. So in this what happens? Well-defined erythematous plaques. They are typically with partially adherent scales. That is what you see in carpet tack sign, seen in discoid lupus erythematosus. Drug-induced pemphigus typically is pemphigus foliaceus is what you need to remember. The last but not the least question for today evening. Next week, say we will discuss 150. After that, 200. Right? Huh. But you should promise to bring more of your friends. Seborrheic dermatitis. Seborrheic dermatitis recurs. Antifungal therapy will help, definitely. And HIV positive individuals, Parkinsonism, they're all the risk factors for development of seborrheic dermatitis, is what you need to remember. So with this, we conclude today's wonderful evening with Dr. Teja is the luckiest person to get Dr. Murli Bharadwaj 100% in the today's session in the Nampalli, right? But good. I always enjoy whether one student, 100 or 1,000 sit before. It is one and same for us because being a teacher all these years, there is a third occipital lobe eye which will see the universal students even if one student is there before. Yeah. So thank you very much for coming.